Cardiovascular system general. At the end of ventricular diastole, flow in aorta drops. Isovolumic relaxation phase of the cardiac cycle ends with opening of atrioventricular valve. During the cardiac cycle, the opening of the aortic valve takes place at the end of isovolumetric contraction. All of the following phases of the jugular venous pulse and their causes are correctly matched except C wave at onset of atrial systole is wrong. AX descent is atrial relaxation. VY is emptying of blood from right atrium into right ventricle. YA descent YA ascent is filling of the right atrium from the vena cava. C wave in JVP is due to tricuspid valve bulging into right atrium. Which of the following is the correct statement regarding findings in JVP? Cannon wave represents complete heart block. In the JVP, A waves are absent in atrial fibrillation. Giant A waves in JVP occur in all except tricuspid regurgitation. So it occurs in junctional rhythm, pulmonary hypertension and complete heart block, but it does not occur in tricuspid regurgitation. First heart sound is soft in all except short PR interval. It is loud in short PR interval. So first heart sound is soft in ventricular septal defect, mitral regurgitation and calcified valve. Loud S1 is caused by short PR interval. Reverse splitting of first heart sound heard in left branch bundle block and atrial myxoma. Loud S1 in mitral stenosis is seen in prolonged flow through mitral valve. Wide split S2 occurs in atrial septal defect. Reverse splitting of S2 is seen in all except WPW type A, that is Wolff-Parkinson White syndrome type A, and LV pacing. So reverse splitting of S2 is seen in left branch bundle block and systemic hypertension and post stenotic dilatation of in AS, that is aortic stenosis. Wide split second heart sound is seen in atrial septal defect and PS. Wide splitting of S2 is seen in ASD, MR and PS. Single second heart sound is seen in tetralogy of Fallot and pulmonary atresia. Loud pulmonary component of second heart sound is heard in pulmonary hypertension and Eisen-Menger syndrome. All of the following heart sound occur shortly after S2 except ejection click. So which heart sound occurs shortly after S2? Opening snap, pericardial knock and tumor plop. Sometimes the following diastolic sound heard during cardiac auscultation: S3, S4 and opening snap. Ejection click is not heard during cardiac auscultation. Third heart sound is seen in all except mitral stenosis. So third heart sound is seen in athlete, it is seen in constructive pericarditis and it is seen in left ventricular failure. True about third heart sound is that it is absent in mitral stenosis and normal physiologically in athletes. Left ventricular S3 is seen in pregnancy, mitral regurgitation, atrial septal defect and patent ductus arteriosus. All of the following statements about third heart sound S3 are true except that it occurs due to rapid filling of the ventricle during atrial systole. This is wrong. What is true is it is seen in constructive pericarditis, it is seen in atrial septal defect and it is seen in ventricular septal defect, that is VSD. S4 is not seen in ventricular aneurysm. S4 is seen in mitral regurgitation, hypertrophic cardiomyopathy and hypertension. Continuous murmur is found in all except mitral stenosis with mitral regurgitation. So continuous murmur is found in patent ductus arteriosus, rupture of sinus of Valsalva and systematic arteriovenous AV fistula. A continuous murmur is heard in all of the following conditions except ventricular septal defect with aortic regurgitation. Continuous murmur is heard in patent ductus arteriosus, coronary arteriovenous fistula, and venous hum. Continuous murmur is present in patent ductus arteriosus, shunt between pulmonary and subclavian artery. Continuous murmur is found in systemic arteriovenous fistula. A continuous murmur is heard in all of the following conditions except ventricular septal defect with aortic regurgitation. So, continuous murmur is present in patent ductus arteriosus, coronary arteriovenous fistula, and venous hum. Continuous murmur is seen in all the following except peripheral pulmonary stenosis. So, continuous murmur is seen in aortic sinus of Valsalva rupture, coarctation of aorta, and arteriovenous malformations. Carré-Combe murmur is seen in acute rheumatic carditis. Carré-Combes murmur, which is false. Delayed diastolic murmur is not true for Carré-Combe murmur. It is seen in rheumatic fever. It can be associated with aortic regurgitation, and it is a low-pitched murmur. An early systolic murmur may be caused by all of the following except aortic stenosis. So, an early systolic murmur may be caused by small ventricular septal defect, papillary muscle dysfunction, and tricuspid regurgitation. Systolic thrill in left, second, or third intercostal space is seen in pulmonary stenosis. Pulse pressure is systolic minus diastolic blood pressure. Wide pulse pressure may be seen in all except congestive heart failure. So, wide pulse pressure can be seen in aortic regurgitation, patent ductus arteriosus, and complete heart block. Pulsus paradoxus is seen in all except IPPV. So, it can be seen in COPD, cardiac tamponade, and constrictive pericarditis. Pulsus paradoxus is present in emphysema, pulmonary embolism, and hypovolemic shock. What is true about pulsus paradoxus? That it is seen in constrictive pericarditis. Pulsus paradoxus is seen in cardiac tamponade, constrictive pericarditis, and severe asthma. Pulsus paradoxus is not seen in HOCM, that is hypertrophic cardiomyopathy, and it is also not seen in aortic regurgitation. Pulsus bisferiens is best felt in radial artery. Pulsus bisferiens is seen in all except tetralogy of Fallot. Pulsus bisferiens is not seen in tetralogy of Fallot. So it can be seen in aortic regurgitation plus aortic stenosis. It can be seen in aortic regurgitation, and it can be seen in hypertrophic cardiomyopathy. Bisferiens pulse is seen in aortic stenosis plus aortic regurgitation, hypertrophic cardiomyopathy, and severe aortic regurgitation. Pulsus alternans occurs in myocardial infarction. Double apical impulses is seen in aortic stenosis. Pulsus bisferiens is best felt in radial artery. Water hammer pulse is seen in aortic regurgitation. Which of the following is not true about hepatojugular reflex? That it is associated with decreased afterload is incorrect. What is true about hepatojugular reflex? That it is seen in pulmonary stenosis, it is seen in tricuspid regurgitation, and it may indicate right heart failure. Positive hepatojugular reflex is found in all of the following conditions except decreased afterload. So, positive hepatojugular reflex is found in all but not in decreased afterload. It can be found in tricuspid regurgitation, right heart failure, and increased capillary blood pressure. Increased capillary bed pressure. Enlarged pulsatile lever is seen in tricuspid regurgitation. Where pulsatile lever and ascites is found, tricuspid regurgitation. Swan-Ganz catheter is used for left cardiac output, pulmonary capillary pressure, pulmonary artery occlusion pressure, and O2 saturation in mixed venous blood. Normal PCWP with pulmonary edema is seen in high altitude. A patient comes with sudden respiratory distress on examination. Bilateral basal craft are present over chest, suggestive of pulmonary edema with normal alveolar wedge pressure. The likely cause is narcotic overdose. Pulmonary edema associated with normal PCWP is observed. Which of these is not a cause? So, bilateral renal artery stenosis is not the cause. What can be the cause? High altitude cocaine overdose or post cardiopulmonary bypass. Left atrial filling pressure closely approximates pulmonary capillary wedge pressure. Transesophageal echocardiography is useful in sinus venosus type of atrial septal defect, dissection of arch of aorta, thrombosis, prosthetic valve endocarditis. Causes of raised juxtavenous pressure (JVP) with hypotension are all except second degree atrioventricular block. So, what are the causes of raised JVP? Cardiac tamponade, right ventricular myocardial infarction, and heart failure. A 36-year-old female, recurrent chest pain and palpitation varying in duration and severity, and 6 to 7 ectopics per minute, possibly supraventriculation, is not related to exertion. Her blood pressure is 86 mm of mercury and pulse rate is 86 per minute. The ideal investigation is electrophysiological study. Continuous murmur is seen in patent ductus arteriosus, arteriovenous malformation, and AP window. All produce continuous murmur except mitral valve prolapse. So, what causes continuous murmur? Arteriovenous malformation, ruptured sinus of Valsalva, and patent ductus arteriosus. Prominent A wave of JVP is not seen in, so none. So it is seen in all of these: junctional rhythm, tricuspid stenosis, complete heart block, and pulmonary stenosis. Normal PQ interval is 0.16 seconds. Central venous pressure monitoring is useful in regulating the speed and amount of fluid infusion. Swan-Ganz catheter is used to measure pulmonary capillary pressure. Electrical alternance in ECG is characteristic of pericardial effusion. A Carey-Coombs murmur heard in a child with multiple joint pain is suggestive of rheumatic fever. A young lady complains of sudden onset of palpitation, extreme weakness, and sweating. On examination, she was found to have blood pressure 90/70 with a regular pulse rate of 180 per minute. Her symptoms disappeared after vomiting, but she complained of polyuria. The most likely diagnosis is paroxysmal atrial tachycardia. All are seen in association with reverse splitting of S2 except complete heart block. So, what is seen in association with reverse splitting of S2? Left branch bundle block and systolic hypertension and aortic stenosis. Water hammer pulse is seen in all except mitral stenosis. Water hammer pulse is seen in aortic regurgitation, anemia, pregnancy, and mitral regurgitation. Which one is not a feature of Larich's syndrome? Continuous bruit over abdominal aorta is not a feature. What are the features? Absent femoral pulse, gluteal claudication, and impotency. Diacrotic pulse is seen in dilated cardiomyopathy. Which is not a major criteria for CCF? None. So all these are major criteria for CCF: PND, Rales, S3 gallop, and cardiomegaly. Framingham criteria for diagnosis of congestive heart failure classifies the following as major criteria except extremity edema. So others are major criteria: acute pulmonary edema, positive hepatojugular reflex, paroxysmal nocturnal dyspnea, and S3 gallop. All are Framingham criteria for diagnosis of CHF, major criteria. Ventricular hypertrophy means diastolic dysfunction. Ejection fraction denotes performance of left ventricle. In Marfan's, aortic aneurysm occurs in ascending aorta. The earliest manifestation in the fatty streak of atherosclerosis is collection of lipid in endothelial cells. Lipoprotein X is elevated in primary biliary cirrhosis. Most common site of aortic dissection is ascending aorta. Aortic dissection is seen in Marfan syndrome. Standing increases murmur intensity in hypertrophic cardiomyopathy. Calcium gluconate is not used in hypokalemia, it is used in hypocalcemia, hyperkalemia, calcium antagonism. A 26-year-old man complains of abdominal distension, swelling of the legs, and easy fatigability. His blood pressure is 90 by 70 mm of mercury and pulse becomes difficult to feel on inspiration. JVP is grossly elevated and rises further on deep inspiration. He has pedal edema, ascites, and tender hepatomegaly. Precordium is quieter with loud and somewhat early apical third heart sound. The probable diagnosis is constrictive pericarditis. Ejection fraction denotes performance of left ventricle. Anacrotic pulse is felt in aortic stenosis. A continuous murmur is heard in all of the following conditions except ventricular septal defect with aortic regurgitation. So, continuous murmur is seen in patent ductus arteriosus, coronary arteriovenous fistula, and venous hum. Carcinoid syndrome produces valvular diseases primarily involving tricuspid valves. Most common cause of orthostatic hypotension is peripheral neuropathy. Most common organism for causing infective endocarditis in native valve is Staphylococci. A wave in JVP is seen in will be large when atria contracts against resistance. Non-cardiac causes of raised central venous pressure include the following except hypervolemia. So, non-cardiac causes of raised central venous pressure include abdominal compartment syndrome, tension pneumothorax, positive pressure ventilation. Which one of the following does not cause pulsus paradoxus? Severe aortic regurgitation does not cause pulsus paradoxus. Cardiac tamponade, constrictive pericarditis, and acute severe bronchial asthma causes pulsus paradoxus. Now match the list. Loud S1 is due to mitral stenosis, loud S2 is due to valvular pulmonary stenosis, soft S2 is due to pulmonary arterial hypertension, wide and fixed S is due to arterial septal defect. The clinical manifestation of Cauda equina lesion include the following except extensor plantar reflexes. So clinical manifestation of Cauda equina lesion include urinary retention, radicular pain, and dermatomal sensory loss. Pansystolic murmur at apex with soft first heart sound is the key sign of which one of the following? It is the key sign of mitral regurgitation. The dicrotic notch on the aortic pressure curve is caused by closure of the aortic valve. The test of choice to detect perivalvular abscess of aortic valve is transesophageal echo with Doppler. The most common form of diabetic neuropathy is distal symmetric polyneuropathy.